So this week, we'll be exploring water, electrolyte, and acid-base balance. First of all, as we know, cellular function is going to require a carefully controlled fluid medium, and that composition needs to stay within very tight parameters. Otherwise, we're going to see that life-threatening disorders can result. We'll be examining water balance with the average daily water intake and losses should usually be equal. We'll look at electrolyte balance, which goes along with the water balance. The amount of electrolytes absorbed in the small intestine are equal to the amounts of electrolytes lost from the body, usually as urine. And then we'll look at acid-base balance, where the body's going to rid itself of excess hydrogen ions. And we just saw some of that going on in the kidneys. All of these balances are maintained collectively by the urinary system, the respiratory system, the digestive system, the integumentary system, and the endocrine and nervous system help regulate that. The cardiovascular system is involved, and also the lymphatic system. So many systems are involved in the balance of water, electrolytes, and acid base. So we begin our life in kind of a soggy condition. When a baby comes out having bathed in amniotic fluid, ingested it, excreted it, most of its body weight is composed of water, about 75%. Whereas the average person is about 55 or 60% water. And in the elderly or obese, we might see it as little as 45% because fat naturally doesn't have any water content. Because women carry more fat, they average slightly less than the average male. So TBW, or total body water, of a 150-pound individual is going to be about 40 liters. The fluid is divided into major compartments. We have intracellular fluid, that's the fluid inside the cells, is about 65%. And then we've looked at a lot of extracellular fluid, ECF, that's about 35%. And extracellular fluid includes tissue fluid, body plasma and lymphatic fluid, and then transcellular fluid, which is sort of a catch-all category. So we see 25% of the fluid is going to be interstitial or in the tissues. 8% of it, it'll be in blood plasma in the circulatory and lymphatic systems. And then 2% goes in this catch-all category. And this category includes things like synovial fluid in the joints, the peritoneal fluids, pleural and pericardial fluids, cerebrospinal fluids. Also in the eye, vitreous and aqueous humors, you'll remember from last semester. And then some accessory fluids like bile, digestive fluids, some urinary fluids, and fluids in the reproductive tracts. Water is going to move between compartments, primarily driven by osmosis. As an electrolyte moves, water follows. Any imbalance that arises is going to be taken care of within seconds by these osmotic mechanisms. If osmolarity in one tissue rises, water is going to move out of the cells. And if it falls, water will move in. So as you can see, between all these different systems, we have a backwards and forwards flow of water. Osmosis from one fluid compartment to another is going to be determined by the relative concentration of solutes in each compartment. So those solutes are electrolytes, the most abundant solute particles by far. Then we'll see sodium salts predominantly in the extracellular fluids, and potassium salts predominantly in the intracellular fluids. As you know, the sodium-potassium pump acts to make that happen. So electrolytes play a key role in governing the body's water distribution. So water balance and electrolytes really go hand in hand. When we examine water gain, we'll see that water can be gained by two sources. First, preformed water, as in it's H2O, it's ingested in our food. And it's ingested in the drinks that we drink. So averagely, that's about 2,300 milliliters per day, 2.3 liters. Most of it, hopefully, coming from fluids that we drink. The second means of water gain is by metabolic water. And this water comes about because of aerobic metabolism. If you'll remember, water is formed at the end of the electron transport chain when the hydrogen ions meet up with oxygen. In addition, we'll see in dehydration synthesis, when we link together two molecules, we release water molecules. So each time we link two molecules together, water is released. And so all this can amount to about 200 milliliters or 0.2 liters each day. Water loss, there's sensible water loss, not as insensible versus silly, but sensible, like you can sense it. It's observable. We lose some water in urine, most of it in urine, about 1,500 milliliters on average. We lose some water in feces, about 200 milliliters a day on average. And then we'll lose about 100 milliliters a day as sweat at rest, so non-exercising. Then we'll also have insensible water loss, which is not silly water loss, but insensible, as in not perceivable. It's water we lose in an unnoticed way. As we inspire and expire, we'll lose water in our breath, as you can see when you expire on a mirror when it's cold. We'll also lose about 400 milliliters a day in cutaneous transpiration. Now, this is different than sweat. Sweat is excretion of fluid by glands, as opposed to this cutaneous transpiration where water is diffusing through the epidermis and evaporating. And you'll notice that if you place your hand near a cold windshield from the inside and draw it away, you can see a little water vapor there. So there's an unavoidable amount of water loss that has to happen each day. It happens in the expired air. As we breathe, water is released. Cutaneous transpiration. We're going to have to lose some sweat each day. You have to have some moisture in feces. And then, as we learned last chapter, we have to have about 400 milliliters a day of urinary output in order to avoid having high content of nitrogenous wastes that are toxic to the body. So the question now is, how is this water gain and water loss regulated? Fluid intake is predominantly governed by thirst, which is a result of dehydration. With reduced blood volume, we're going to see reduced blood pressure, and we're going to see an increase in the osmolarity of the blood. This increase in osmolarity in the blood is going to have an effect on the osmoreceptors in the hypothalamus. These osmoreceptors will respond to angiotensin II, which is produced when blood pressure drops. And we're going to see a rise in osmolarity of the extracellular fluid. Also stimulates the osmoreceptors. Both of these are a result of a drop in blood volume. The osmoreceptors do two things. They're going to communicate with the hypothalamus and the cerebral cortex. The osmoreceptors are on the hypothalamus. They tell the hypothalamus to produce antidiuretic hormone. And as you know, the antidiuretic hormone then goes to produce aquaporins, and the aquaporins promote the water retention or water reabsorption from the kidney tubules. The cerebral cortex is going to elicit a conscious sense of thirst. Within just a 2 to 3% increase in plasma osmolarity, we'll see that these receptors will instigate intense sense of thirst. Salivation is also inhibited with thirst. We have sympathetic signals from thirst centers that go to the salivary glands and they stop them from producing saliva. Also, we'll see that saliva is produced by capillary filtration. So in a dehydrated person, this is going to be opposed because there's lower capillary blood pressure. Thirst satiation mechanisms, a couple of things come into play. First of all, we look at long-term inhibition of thirst. When we see that there's water that's absorbed from the small intestine, it'll reduce osmolarity of the blood, and that'll stop the whole osmoreceptor response we just looked at. It promotes higher capillary filtration, makes the saliva more abundant, more watery, less thirst. However, these changes require about 30 minutes to take effect because the water has to be absorbed by the small intestine and has to reach the hypothalamus and tell us that we are satiated, as in unthirsty anymore. So then short-term inhibition of thirst comes in. When you initially have a drink of water, the coolness and the moistening of the mouth actually quenches the thirst directly. Distension of the stomach and small intestine from the added fluid volume will also cause satiation of thirst fairly rapidly. And this will only last about 30 to 45 minutes. It has to be followed by actual fluid being absorbed and making its way to the hypothalamus and shutting down the desire to drink or thirst. Now, regulation of water output. There's only one way we can really control any of the water output, and that's through varying the urine volume. So the kidneys can't replace water or electrolytes. They can just control the release of water and electrolyte. There's several mechanisms. First of all, changes in urine volume are going to be linked to adjustments in sodium reabsorption. As sodium is reabsorbed or excreted, water is going to follow. So the action of antidiuretic hormone is going to concentrate the urine. Again, as you know, the ADH is going to stimulate the production of the aquaporins, and so we're continuing to reabsorb water at a higher rate when antidiuretic hormone is present. However, aquaporins are not involved in sodium reabsorption, so the sodium is still excreted. So the action of antidiuretic hormones slows a decrease in water volume and slows the increasing osmolarity by absorbing more water, thus decreasing the osmolarity, and it also concentrates the urine, so we have a much thicker urine but more water retention. The action of antidiuretic hormone release is inhibited when the blood volume and blood pressure gets too high or blood osmolarity is too low, and so we see the reverse effect. Aquaporins are not synthesized. We're going to see more water loss in the urine. So to complete our section on water balance, we'll look at some disorders of water balance. We'll begin with fluid deficiency. There are two types of fluid deficiency: volume depletion and dehydration. Volume depletion is otherwise known as hypovolemia, and this occurs when we have a proportional amount of water and sodium that are lost, and it's lost equally from all compartments. This can happen because of hemorrhage, severe burns, chronic vomiting, or diarrhea. And it results in the total water volume is going to decline, but the osmolarity is remaining normal. In dehydration, or true negative water balance, we'll see that we lose significantly more water than sodium. So the total body water declines as the osmolarity rises. It results from not drinking enough water, from diabetes where we're losing too much water in the urine. It results from ADH hyposecretion, which we saw in diabetes insipidus. It results from profuse sweating or the overuse of diuretics. Infants are far more vulnerable to dehydration because they have such a high metabolic rate and they have high demand for urine excretion in order to get rid of these wastes. They also have immature kidneys that can't concentrate urine as effectively as the adult kidney. And they have a greater ratio of body surface area to mass, so they'll lose more water through transpiration. In the most serious effects of dehydration, we'll see circulatory shock, which results in neurological dysfunction due to dehydration of the brain cells. And dehydration is a very severe cause of infant mortality because of diarrhea. In cold weather, we need to be particularly attentive to fluid balance. So the body conserves heat by constricting blood vessels in the skin, which forces the blood to a deeper level of circulation. Doing this results in a rise in blood pressure, which of course inhibits the secretion of ADH. It increases the secretion of atrial natriuretic peptide, which results in urine output being increased and blood volume being reduced. So cold weather can result in respiratory and urinary losses, causing a state of hypovolemia. Exercise can dilate the vessels and skeletal muscles, and in order to supply those muscles with enough oxygen and nutrients to maintain the activity, and that can leave insufficient blood for the rest of the body and bring on hypovolemic shock or fainting. Dehydration can result from excessive sweating. When we see water loss from excessive sweating, the sweat's going to be produced by capillary filtration. So the sweat glands draw it from the capillaries, we release it to the external environment. We can see blood volume and pressure dropping, again osmolarity rising and all the effects that go along with that. Blood is going to absorb the tissue fluid in order to replace its loss that occurred through capillary filtration. And the tissue fluid is going to pull from the ICF or intracellular fluid. So all three compartments, the circulating blood, the intercellular fluid, and the extracellular or tissue fluid, are going to lose water. So for 1 liter of water that's sweated out, about 700 milliliters of it would come from intercellular fluid inside the cells, and about 300 would come from the tissue fluid. And that's in order to maintain the blood volume so that we can supply the nutrients necessary. Fluid excesses are much less common than fluid deficiencies because the kidneys are very, very effective at compensating for excessive intake by excreting much more urine. There are 2 types of fluid excesses. There's volume excess and hypotonic hydration. So volume excess, again, is about having water and sodium retained. So the extracellular fluid is going to remain isotonic. And usually this volume excess can be caused by aldosterone hyposecretion or renal failure. So we're not getting enough water out through the renal corpuscle, or there's too much water being retained, recaptured. Hypotonic hydration, otherwise known as water intoxication or positive water balance. You may remember a few years ago there was a strong incidence of death from hypotonic hydration in kids that had been taking ecstasy, which stimulates a strong thirst response. This might be one of those topics that you want to take on as a special topic, examining how hypotonic hydration has its effects. But basically, we have more water than sodium is being retained or ingested. So there's an imbalance, which means the extracellular fluid becomes hypotonic because we're having more water pulled into the same osmolarity. That's going to drop the osmolarity. And that's going to cause cells to swell. Can also, with hypo, like if we're very dehydrated and just drink water instead of electrolytes and water, then we'll see that the water rushes in to flood the cells and the cells swell. And this can cause pulmonary as well as cerebral edema, so swelling in the brain. And that's what happened with the kids in the ecstasy, as we had extra water accumulating in the brain to such an extent that it caused death. So here's a figure that exhibits the blood volume and fluid intake. It shows that the kidneys are very adept at compensating for excessive fluid intake, but they're not so adept at compensating for inadequate fluid intake. You see down here in the range of danger, if you're intaking less than a liter and a half a day, it's very dangerous because the blood volume will drop with that decrease in intake. However, if we're intaking 2 to 3 on average, of course, this is going to be at sea level and normal temperatures, so we're much more susceptible to this hypovolemia here at altitude. We can increase our water intake by many liters a day and we'll still maintain the same blood volume. Finally, we look at fluid sequestration. Fluid sequestration is where we see excess fluid accumulating in a particular location, so it's not equal among all the compartments. The total body water volume may be normal, but the volume of circulatory blood may drop to a point of causing circulatory shock. The most common form of fluid sequestration is edema, where we'll see abnormal accumulation of fluid in interstitial spaces, so between the cells. Intercellular fluid is going to increase, and that causes swelling of tissues. Other causes, we can see hemorrhaging, blood pools in the tissue and so that's lost into circulation. So if we have a big bruising or internal bleeding or external bleeding, right? And then pleural effusion is where, because of some sort of lung infection, we can see fluid accumulating in the pleural cavity. And that will, of course, decrease the respiratory capacity, so on and so forth. So that concludes the section on water balance. Now you're ready to move on to the next section, electrolyte balance.